Welcome to Complicating the Narrative. I'm your host, Salma Abdullah. This episode is part of our Better Ways of Knowing mini-series, which we are running on this feed throughout the summer. The Better Ways of Knowing project asks how we should produce, evaluate, and act on knowledge if the goal is to continue to improve the health of populations. And in this series, we are sitting down with people who were part of our first convening to hear their reflections on that question. My guest today is Professor Whitney Robinson. Whitney is a social epidemiologist at Duke University School of Medicine, where she works on inequities in gynecological health. In this conversation, we discuss why she moved from population-level obesity research to gynecological health, what it has been like to do social epidemiology work from within a clinical department, why she left a field with a rich evidence base, and what public health misses when its researchers are disconnected from the communities and lives they study. We'll also talk about narrative, advocacy, and what it takes to be ready when the moment for change arrives. Whitney, welcome to the podcast.
Thank you.
So first, and I don't see that you're wearing it today, I wanted to talk a bit about you moving to hysterectomies and gynecological work as your main area of interest. So I wanted you to tell us a bit about why did you make that move and what interested you in that area.
You're probably referencing the fact that I often wear a necklace that has the uterus and the fallopian tubes and the ovaries on it. And I love wearing it because it's such a good conversation starter because a lot of people really want to talk about these issues. I started out as a social epidemiologist, and I'm really surprised that I've ended up working on healthcare issues around hysterectomy and other treatments for gynecologic health. But I think it actually makes sense because when you think about something like hysterectomy, it touches on so many different aspects of life. It's not just a treatment for conditions like fibroids or cancer or bleeding. It's also really intimately tied to fertility, which is really basic in population health. It's really tied to that issue of being able to bring life into the world, but also at a certain point wanting to limit your fertility, or sometimes the treatment having this impact of limiting your fertility, and it's very intimate. So I think I like that. It affects a lot of people. Hysterectomy is the most common surgery besides C-section among non-elderly women, which surprises people. So I think it fits at this population level where I'm very interested in things that affect large groups of people that change across the life course. The meaning of this surgery is very different for a 20-year-old than a 50-year-old. That butts up against a lot of religious and cultural norms. So all the things that I love about being a population health researcher, the potential for big impact because you're talking about something that's really important to a lot of people, fits in with hysterectomy and gynecologic work.
I have a lot of questions here, but two of them, I guess I'll start with. The first one is, why do you think, and I've had those conversations before, it is always jarring when people hear statistics about things that affect women that we just don't necessarily talk about that much. I think menopause has been something that just suddenly became an important issue because and I'm very happy that Halle Berry decided to make this an issue, but it doesn't seem like it's an issue of an important impact on the population level. It's very hard to make them front and center for all the interventions we want to have. So I don't know if you have any ideas of why that is the case. Is it just the sensitivity around those issues, cultural sensitivity?
In the U.S., I think that this has been something that's not researched, so we just don't know much. We don't have much of an evidence base. And one of my theories and something I've written about is that a lot of it is about women's well-being. And so much of our health research in the U.S. is about, are you about to die? Do you have an acute illness? And we're pretty good at treating acute illness in the U.S. And fertility to some extent. But I think midlife women, when they're not really in the fertility business and they're not going to die of a lot of these conditions, even though they dramatically affect your quality of life and they can be kind of hidden, it has just not been a priority. So I think there's social taboos against talking about a lot of these issues, but also literally the way we do research about health has kept it hidden because there's just not much research, there's not much knowledge, there's not much evidence base.
Yeah. It is interesting. I just told students a few days ago who are interested in going to medical school and public health that the U.S. is a great place if you have an acute issue or if you're 75 or 85 or older and you need some interventions to keep you alive, but not necessarily for anything in between. But it's interesting to me because you said this is the population perspective you have. As someone who came from the other side of things, a clinician all the way to epidemiologist, I have to say, I find it very hard to translate anything in clinical practice to something that I feel improves population level outcomes. I wanted to ask you, what is it your experience has been so far working at, I think you're in the medical school, right? Like in a clinical setting with
Yes.
clinicians.
I spent almost all my career in a school of public health. So I got my
Yeah.
PhD in epidemiology. I did my postdoc in an epi department and was on faculty in an epi department. So I've been at Duke in School of Medicine and OBGYN for 5 years,
Hmm.
which the time has flown by. And I moved there deliberately for my science because, given how small the field is, a lot of the center of gravity for gynecologic health is still in medicine. So I'm like,
Yeah.
okay, this is just where a lot of the energy happens to be. But I also do get the benefit of like new ideas. So,
Yeah.
like, something I want to work on now. As an example, there's this big move to do ambient listening, basically
Hmm.
recording clinical encounters and having AI companies write the summaries of the notes to try to reduce, the physicians in the US have to spend so much time writing up notes to justify their
Yeah.
care. And so this was kind of rolled out. They did some pilot testing early in 2025. And I'm sitting in on faculty meetings and I'm like, wait a second, we're recording all of
Yeah.
our visits? I would like to use
Yeah.
this for research. So they're not even thinking about it for research. But being there at the front end when it's being rolled out clinically helps me think about new research avenues. And so now I have a research area I'm trying to build out in this area to understand interactions and clinical encounters. I also just appreciate the clinical perspective in that clinicians move fast. They just move
Yeah.
faster than I will think about an idea literally for 5 years, a decade. Like that's the pace. But they'll have something and they'll roll it out, just like this ambient listening thing. There was a
Yeah.
pilot study in 2025. Then they rolled it out to the healthcare system. And now, in my preliminary data, the majority, maybe 60% of visits for some of these issues are using this technology.
Hmm.
And you think about the pace of change sometimes in public health and other aspects, and it can be really
Yeah.
slow. And so I think I like being in an environment that pushes me a little bit in that way. And
Yeah.
also, it just helps me be real about what care looks like. Just the range of care is really dramatic. I'm embedded within a health system that has an academic medical center, but then also other practices. And, my colleagues, I think, are really extraordinary in trying to give care. But even within a large health system like this, there's just a range of people's experiences and the way people do things.
Yeah. And actually, so I interviewed someone a while ago who does work on fall preventions. And she came from a physical therapy background. Fall preventions, for those who didn't listen to the episode, usually if you have one fall, more likely than not, you're going to come back with another fall to the
Yeah.
hospital. So she tried to work with the hospital to understand if they can reduce the rate of falls. And she thought it was hard. I don't know if I agree, actually. I think, yes, clinicians, in her mind, which is understandable, she feels sometimes, yes, people have different perspectives. Or like the goal of the hospital was if someone comes in and they have a fall, how do we get them better and get them to leave, not to prevent them from the next fall?
Yeah.
I don't know if like I got into medicine and then public health because I'm interested in people being healthy. But so I think I understand there are structural incentives, but I also think a lot of people who work even in clinical setting, they really care about the prevention side of things. I don't know what has been your experience
Yeah.
bringing the public health perspective to a clinical setting.
I think that the health system has
Yeah.
its own incentives. And
Yeah.
sometimes where they align well with population health incentives, you can move things fast and it
Yeah.
can be very powerful. So that combination of the fact that so many people in healthcare want to do good, sometimes something really fits with the incentive structure and it can have a big impact. If you get those three things together, things can move fast and be powerful. But where
Yeah.
the incentives don't align, I think it can be harder. Or sometimes just having a champion. I think
Yeah.
I have come to appreciate how important leadership is and the difference between having a leader who can get buy-in and champion things and somebody who's not interested in your thing
Yeah.
or who's not especially effective can be really big. So
Yeah.
I think a lot about that as well. But like something like the ambient listening, I think some people are attracted to technological fixes. They feel more accessible than fixes that
Yeah.
rely on human beings
Yep.
and
Yep.
behavior change and
Yeah.
like hiring more people. And the solution of clinician burnout is such a big problem. So I think the
Yeah.
health system, anything that says, oh, we can reduce burden on your clinicians within the constraints of our system, I think is attractive. So
Yeah.
I think trying to understand the incentives is really key. And I'm not that good at that, but I think good leaders are very savvy about that.
Yeah, yeah. So I want to talk a bit about social epi and better ways of knowing. And disclaimer, the first time I heard your name or heard you speaking, I don't know if you would remember, I was a student and there was the SAR conference, the Society for Epidemiological Research Conference. There was a keynote presentation for two people, I think, social epi and causal inference and how they can work together, Sandra Gray and Miguel Hernan. And you had a question in the audience. And I really appreciated your question. But I think to me, then it was interesting that it was clear also, I think you wrote and thought about social epi and causal inference. So I wanted to ask what made you, I know we talked about why you're really interested in hysterectomies and gynecological issues because they're really important, but what got you to move from, at the time, I believe you work with obesity related research and
Yeah.
social epi, and just remembering how passionate you were about the discussions on social epi and causal inference to more clinical settings. So can you talk a bit about
Yeah.
that and why did you make the move?
I still see myself as being really grounded in social epi. The definition of social epi I use comes from a methods book. I think it's called Methods in Social Epidemiology, and Jay
Yeah.
Kaufman is one of the authors or editors of it. I don't know what edition they're on. But this idea that social epi is basically the difference between seeing epidemiology as a branch of veterinary science for humans
Yeah.
versus, everything else that makes us human, our
Yeah.
free will, the way we organize into societies, just human agency. And so I
Yeah.
think there is this biological aspect just about human beings being another mammal that we want to optimize for health, as if you were a veterinarian, and the world of everything else that impacts us. And I think some people who do health research forget that part. Like
Yeah.
maybe it's in the back of their mind, but it's
Yeah.
really important because, we're not just another mammal. And
Mm.
so the kind of things that I think about with social epi are like people exercise free will. So even something like gynecologic health, it's something that's patient preference sensitive.
Yeah.
So some things in healthcare, if you come in and you have a gunshot wound that is making your lungs unable to breathe, like they're just going to do things to you. You don't
Yeah.
have a say in it. There's a very straightforward protocol of what they're going to do. But so many things around gynecologic health, it is supposed to be in tandem with the patient. And so I see
Mm.
that as part of the social epi and then all the other things I talked about. But I actually worked in obesity for a long time, which fits a
Yeah.
little bit more into that social frame because, you think about something that is very common, affects large swaths of people, probably has some like causal factors that are really common, and that should be modifiable because we've
Yeah.
seen rates of obesity, they vary so much across time, they vary so much across place. And so
Mm.
it seems like a perfect thing to look at social epi. And there's all these differences across population groups, all the things about social stratification. It changes across the life course. You see changes over time. You see changes over place. There's some human stuff that's going on to explain this variation. That's not
Yeah.
just about something inborn in people genetically. So I love that aspect of obesity epidemiology.
Yeah.
Another thing I loved about obesity work was the richness of the evidence base. So this is a field where you have really good surveillance data.
Yeah.
So like, rates. I can ask you like, what's the rate in this population in this year and get it. Whereas a lot of other things like in gynecologic health, I can't. I can't tell
Yeah.
you the prevalence of endometriosis like
Yeah.
in the state of Georgia in 2003. But with obesity, you can. And you also have randomized clinical trials that go over
Yeah.
multiple years. You have good animal models. You have some other good in vitro models. You have natural experiments. It's so methodologically rich. But I ended up leaving that field because despite the methodological richness, the paradigm stayed very simplistic in a
Mm.
very energy in, energy out, human agency. It's just individual willpower. You need to eat less or move
Yeah.
more.
Yeah.
That's not what the evidence showed. Because
Mm.
the evidence says, hey, we see this rise across all these different population groups in this time and in different societies in these times, which points to environmental exposures, like a big environmental change. We
Yeah.
know from the lab studies and the RCTs that maybe in the short term, energy restriction makes you lose weight, but in our modern environments, the biofeedback that will then ratchet up appetite is so strong, which
Mm.
makes sense. The drive to get enough calories to live I mean, that's as close as like thirst and breathing.
Yeah.
The human animal is going to have this drive to not be in a calorie deficit. And I think once the system gets dysregulated, even in somebody who looks overweight, they might be experiencing the threat of calorie deficit like somebody who's starving. And
Yeah.
so all of that biologically makes sense and is there, but there are so many vested interests and corporate interests who don't want us to think about it that way that I really saw the power of the food industry and other actors to keep us in a paradigm that was wrong. And it just felt
Yeah.
really hard to be in a field that was so scientifically rich that worked on some wrong paradigms. And there's like a few cognitive tricks that make it
Mm.
easy for that to happen that are especially prominent in obesity.
Yeah.
I think one of them is the difference between the short term and the long term, because calorie restriction does work in the short term. But
Yeah.
like if you go out 3-5 years, it doesn't, and actually
Yeah.
looks like it dysregulates the system even more. And so
Yeah.
I think people have this intuition: if this works in the short term, I can see it work in the short term. This must also be the paradigm for the long term in the population, which isn't true. I
Yeah.
think the idea of critical periods, people sometimes don't understand. Something that happens to you early in life could have a long-lasting effect that might not manifest until later.
Mm.
So like a change in your food environment when you're a kid, it might not seem that important. The kid might not even have higher weight than normal in that time period, but then later their energy balance is more dysregulated. And I think that also is hard cognitively for people to connect something that
Yeah.
happens to you decades before to later. So this is one of my hobby horses. So I think I left the
Yeah.
field because I was just frustrated in making change because the paradigm seemed stuck in the face of really good evidence that the paradigms weren't right.
And I think this brings us to, like, it is a pet peeve of mine as well. And increasingly, maybe I should stop reading econ papers when I realize also that, I mean, I am a full blown advocate of addressing food deserts, but clearly the evidence shows like this is the thing we decided also to focus on, to say, oh, if food deserts is the problem, it's going to solve everything. But at least from the evidence we see, it's not going to solve everything. And
Yeah.
it goes back to the industry. And what do we do with the industry? And we see it in other countries. I do some work on commercial determinants of health. We get more regulations in a high income country, and I see that in my country, in Sudan, where the corporations just take the food and introduce it to a new environment that has less regulations. But then,
Yeah.
what would be a good way to improve our ways of knowing in public health? Because I share your frustration and I fully understand them. But I keep thinking, then, and this brings us back to what we're trying to do in this project, is what should we focus on, that knowing all of those things, especially when we know we have so much data. And sometimes that's what frustrates me about the work I do in social epi, especially when it comes to mental health. I'm like, I don't know how many times I can describe to you that mental health is affected by income, by job loss. So it's
Yeah.
just, I just don't know then what should we do moving forward thinking about those issues.
I don't know.
Yeah.
But I will say this is the social part of the work we do.
Yeah.
And human beings and societies have stories and they have
Yeah.
narratives that drive things. And there are points where a narrative can shift and there can be an inflection point.
Mm.
I think some of it is to be ready when that
Yeah.
happens. So that's why I think a lot of us who've worked in obesity feel a little bit conflicted about the MAHA movement. Because on the one
Yeah.
hand, like maybe this is an opportunity, but also it's some of the leaders are so in bed with the corporate interests. Is it really an opportunity? And so, but trying to be open
Mm.
to the possible leverage points. Charismatic leaders can shift narratives. So
Yeah.
thinking about the things that can shift narratives, taking advantage of narrative shifts, a lot does come down to politics.
Yeah.
And so the extent to which people want to get more involved in politics and influencing political power, I think is a question that hasn't been the route I took, but I could see some people taking that
Mm.
and it being effective while acknowledging that politics can very much shift in its narratives as well. I have a colleague, Kimmy
Mm.
Dole,
Mm.
who just wrote a lay press book about Black
Mm.
women's gynecologic health. She does the same thing as me. We like publish in our journals. We do all the things. But she's like, I'm going to write a book for the lay press because people keep asking me for it. And also it just gets to people in a different way.
Yeah.
And part of her book, it's very much grounded in science and then actions people can take as individuals. But then it also has these stories.
Yeah.
And I think people respond to narrative in a way
Yeah.
that they don't respond to statistics. So that's a grab bag of thoughts.
Yeah. No, I like those. I want to ask more actually about social epi and causal inference, but I like this thread, so I'm going to keep going with it because I really appreciate that. And maybe taking just a more inward look. And this might actually link to in public health, it seems to be, at least in epi, we're engaging more in the methodological arguments about causal inference and epi or social epi versus thinking more about narrative changing the conversation. And I'll just put it out there for you. When I started I really wanted to do this podcast because it was driving me crazy, some of the conversations we were having. And then I had someone say to me, "Oh, so are you leaving academia?" And it's just, it doesn't help. Like I said to them, like, I think I've published enough now. I think I want to do something alongside that. But that was just the immediate reaction of, oh, then I guess you're no longer interested in doing scholarly work. So why are you doing this? So that's one. The other one, and I would love your reflections on both, is I think you said this during the convening, or we discussed this during the convening, of like, are we even sometimes engaging with the communities that require that type of narrative? I really loved some of the examples you gave on how you keep yourself grounded in the communities you work or you live with. But I sometimes wonder, just like, I mean, I will be honest, I lived in Boston until I moved to St. Louis. It just felt like I lived in one group of people who just say the exact same thing, and it's actually helpful to hear people from different perspectives. But yeah, looking inward, how do you think we can think about what needs to change in the topics that we discuss in social epi that would actually lead to population level changes?
When I was in grad school, so this was 2001 to 2008, one of the big debates was the difference between research and advocacy. And there needs to be like a bright line between research and advocacy, and also an elevation of the quantitative over the qualitative. And so that's the stew in which I was raised. And I love numbers. I love data. So I was very comfortable. I'm like, I'm going to do my part. I think advocacy important. I think mixed methods and qualitative work is important, but I'm going to do my little quant thing in my role. I think gradually as you mature and you want to have more influence, that usually softens. But I think COVID really turbocharged that. Because for me in the U.S., where I live in North Carolina, and having a lot of family across the South, like working class Black people who are really at the front lines and very much affected, I really stepped into doing more public facing, like advocacy and communication. And also there was just such a gap in leadership. Like this was during the last Trump administration. I just felt like there was a real gap in leadership and direction. And I think people were looking for information. And I'm like, well, I don't have a lot of practical skills, but I could do some research and give you some advice. And during that time, I published in community newsletters, but I also just talked to people. And I also had small children. So that's another thing. I myself had to make decisions about childcare for my school, for my children. My children had been in full-time childcare. So there was a very practical decision I had to make that couldn't just wait for me to kind of dither academically. I had to make a very specific decision. So I had to dive into this research for me. And then other people were asking me, how are you making these decisions? And so I think it led me to also talk to more people. And then as far as schools and COVID, also talking to some of my neighbors. And a lot of the assumptions from the academics were, people who are low income, most need the schools because their kids can get nutritional supports. But then when I talked to people in my neighborhood with that profile, no, a lot of them were like, that's not my main concern. My main concern is more just my exposure, and I live in an intergenerational household. And also, some of them were like, my kids aren't even in the public school because I think they kind of failed me on teaching my kid to read. They weren't teaching my kid to read correctly. This ties into another thread of something I've become an advocate about. And so just realizing that I think a lot of my colleagues who are academics just make a lot of assumptions about people without actually talking to people. I don't know what that is, but maybe it's this thinking that you can split off advocacy and community work from kind of your quantitative work has left us in a hole. And it particularly bothers me about social epi because social epi is fundamentally very humanistic. But a lot of the things that I saw were not humanistic. I think that some people that actually stand out as being really good at the humanistic side during COVID were people who work in harm reduction. So one of the people who I loved to read, Julia Marcus, published some work in The Atlantic, and she does work in HIV, men who have sex with men, and harm reduction work. And I think people who really are working in marginalized populations, not just talking about marginalized populations, realize like these are people too. And
Yeah.
yes, like their health condition is important, but also like they want to have fun. They want to go
Yes.
out. Like
Yep.
they have people who depend on them for things. Like their lives are rich. And you have
Yep.
to think about the whole person. And I think a lot of people who work, I think about people who work in populations with HIV. I know somebody who's a liver doctor who works with a lot of people who have alcoholism and who are chronically sick. I think it gives them this perspective that like this health condition is important and this is what I'm focusing on, but their lives are more
Yep.
complex than this.
Yep.
And
Yep.
I think with COVID, a lot of the social epi people like just forgot about that. Like the disease is important, but it's not everybody's
Everything.
life. You got to think
Yeah.
about other aspects of people's life. If you
Yeah.
want to do something that's effective and get buy-in and just be human with people.
Yeah.
I don't
Yeah.
even know if that's relevant to what you asked.
No, it really, really is. And I tell this story a lot, but mostly to students. It's, I think, what humbled me during COVID, like really, really early on, which I needed. I moved here to the US. My entire family's in Sudan. And right after COVID happened, we had a civil war.
Yeah.
And then I would call my mom in Sudan and I'd just be like, everyone stay inside. I also completely forgot Sudan. Very different demographic structure, very
Yeah.
different ventilation. Like everyone lives outside. So I didn't think,
Really?
I was in the US. I'm like, you just should all just do what I tell you.
Yeah.
And then my mom was like, you know what? So I'm just going to be honest with you. Seems like a thing, this COVID thing that you were talking about. But we now have to wait in line in the bread line for like 5 hours. So your
Yeah.
cousin is just going to leave now to wait in the bread line for 5 hours. And then we're going to send someone else to stay after her. And that's what we're going to do right now. But thank you very much for that advice. That was so humbling. As I moved to my very nice new apartment in Boston, that was just like a very good lesson I needed, which is, I actually wonder, like, how would it be helpful just like to hear things like this in academia? And I don't know, especially, yeah, if you're a card carrying, especially social epidemiologist, like going back to knowing better, I just don't know how we solve it. Like, do we just incorporate that you just need to go out to the bar that exists in your community and actually listen to people before you can write something? Like, there must be a better way for us to do this. And again, like you, I love data. Give me a bigger data set and I will be happy. But I really struggle with like, how do we move forward on this? And how do we make communication, dealing with communities, working with communities as something that is also rewarded in academia? I don't know if you have thoughts on that, but yeah, I agree.
I don't know, but I think as you're, coming
Mm.
into Epi, when I went to grad school, I wanted to learn all the statistical techniques,
Yeah.
and it was also valorized and it was elevated. But there were people, and I think there have always been people who said, hey, you need to learn more of this history. You need to learn more of this theory. And
Yeah.
they were not elevated. And so incentives,
Yeah.
the incentives maybe from the NIH that didn't value
Yeah.
those things, and the incentives from other funders. It might get back into kind of what society incentivizes, what the political system and the funding systems incentivize. And so I don't know how to change that structurally. Also, education is tough. I sometimes have students who will come back to me literally a decade later after taking a social epi class or another class from me and say, I didn't understand what you were trying to tell me, but like I see it now.
Yeah.
And so that's kind of validating, but it's also frustrating because I'm like, oh, I wish there was a way to get them to see the connections when they're in school, but maybe you just have to live.
Yeah.
So I don't know.
Maybe you just have to live is amazing. Maybe that's part of the problem. We're all nerds who wanted to do just write about big statistical analyses, and we went through the schools, and now we just get into an academic environment, and that's how we live for the rest of our lives. But no, I really fully agree with you. And I wonder if we get to a point where maybe we're forced by the the world to do it. Like everyone now has Claude, has ChatGPT at their fingertips, and they might not listen to us if you just seem very, very disconnected from the real world. So maybe we'll just be forced to change the system because that's where we live.
I don't know which way it's going to go because honestly, dealing with people and being in community is inefficient. Like it is not efficient, you know?
Yeah.
And so in this drive towards efficiency, it pushes away from that. But then I also see young people being like, what is this? Like,
Yep.
touch grass,
Yep.
like, give me a human experience. And so I don't
Yep.
know what's going to win out.
Yeah. Yeah. No, fully agree. So then thinking about what we're doing, and I love your thoughts because we're supposed to do this project for 2 years and
Yeah.
talking with communities next convening, hopefully we're going to listen to decision makers in DC to figure out like what is needed, what is the type of evidence needed from us. And
Yeah.
the state of the university right now, what do you think we should do, especially in this convening, but also in public health moving forward, bringing all of this perspective here that would actually move us into being effective in improving the health of the population?
I do think it's a good idea to try to draw connections with political stakeholders. But
Mm,
I think you have to treat it just like building community ties with any other
yeah.
group, that it's
Yep.
slow, it's inefficient. Sometimes the way they think about things is so different. And so I think it's an investment in the long term that might not show immediate dividends. But I think understanding what they want. I'll talk a little bit. My
Yeah.
husband ran for local public office
Mm,
in 2025. So now I have a glimpse a little bit
mm,
into how local government works. And it's just people. Like,
yeah.
it's people in systems, but it's
Yeah.
just people to kind of a
Yeah.
shocking degree. Where, like, if
Yeah.
you get the right person on board with your thing, or if you have 5 people to show up at a small city council meeting, you can really move things because it's just
Yeah.
people. The people want to be liked, the people want to feel good. So I don't know. I think keeping the connections, I think
Mm,
learning about what they want, looking forward to anticipate things down the pike. The people I know and respect the most in community work, they learn the system and they
mm,
learn the levers in the system, and they try to keep abreast on things that are brewing, and they're always
yeah.
looking, so what's the angle that could help me move something forward? And it might not be obvious. And so it is a big investment, but I think learning the system, learning the levers, and just keeping in touch to understand, oh, is this person's incentive changed? Or, is this bill coming up that actually has
Mm,
this weird component? And, this person who's not on my political team actually kind of has a hobby horse that's aligned with this thing I'm interested in.
yeah.
I guess looking for windows of opportunity.
Okay. And what should we do in academia?
It's such a varied landscape. So, like, I went to
Yeah.
Harvard undergrad,
Yeah.
and I just got back from my 25th college reunion.
Yeah.
So that's like one end. I've worked for state university systems in North Carolina that are heavily influenced by our legislature,
Yeah.
which is very different than a legislature in California or New York. I've worked at a
Mm,
private university. So I think, first of all, just the challenges that universities face are really, really varied. And so
yep.
I think sometimes trying to put universities in one bucket obscures that. I don't know. I feel like it's such a time of flux.
Yes.
And I feel like it's such a time where a lot of universities are kind of on their back foot, a little bit
Yeah.
retrenched. I think just trying to stay in it, stay engaged, and literally stay open for some
Yeah.
small institutions is a goal. So I don't know. I mean, telling your story, but also making your students feel valued and
Yeah.
loved.
Yeah.
And your
I-
faculty and your staff feel valued
Yeah.
and loved. Maybe we could get that's like an achievement.
Yeah. I think I really wonder in age of AI, maybe just going back to yes, all being human and like we're gonna show you what is your value here as a human might be a good place for all of us to start. Uh,
Yeah.
Highlight. I have one last question for you because a student asked it to me on Friday and I couldn't answer. I gave a guest lecture about the social determinants of health, very general, big. What are the trends happening in the population?
Hmm.
And then the student asks, he was getting into medical school. Okay, so what should I do now? It's great. I learned about all of those things that affect the health of populations. Do you recommend that I just go narrow and focus on one problem? Should I just go broad and look at all of those trends all the time? And I don't know what would be my career advice to him. He's definitely going to medical school. I
Yeah.
don't know if you have a career advice.
Sometimes money is an issue. And so
Yeah.
sometimes people make a decision because financial reasons or life
Yep.
reasons where you need to live, family considerations. Putting all that aside, I would try to find something you're really into.
Mm,
And I know people are like criticizing sometimes the following your passion thing, but it's going to be a long road. I feel like healthcare right now is under a lot of stress.
mm,
This is the same advice I give people who want to get a PhD.
mm.
Like, you need to prepare that it is going to be difficult and challenging. And so having something where you have a lot of intrinsic motivation, I do think can help. There is need all over. And also, you don't know where the need is going to be. I mean, think about people who were in infectious disease like 10 years ago, where it was like, oh, infectious disease is over. Like, it's just about chronic disease. Like, you don't know what's in the horizon. Even think about obesity medicine and how much it's changed. So I think sometimes trying to pick jobs based on what seems hot at the moment is a disservice to people because things can change. So instead, I think I would lean towards first your practical needs, but then kind of your intrinsic motivation, because I think then wherever you are, you have the possibility to make the most difference and also stay in it, because a lot of people are getting burnt out and leaving healthcare. So also kind of where do I think I can really stay and overcome challenges and persevere even when things get tough.
Whitney, thank you so much.
You're welcome.
This episode was edited by Catalina Melendez-Contreras with marketing by Kinkini Bahadri. Complicating the Narrative is supported by the WashU Pursky School of Public Health. And this miniseries is part of the Building Better Ways of Knowing project, funded by the Robert Wood Johnson Foundation. If this conversation was useful to you, please pass it along to a colleague who cares about the future of public health. Thank you for listening.